Welcome. My name is Dina Safe. I'm an emergency physician at LA County, USC, and Mission Hospital Laguna Beach in California. This lecture will demonstrate how to use bedside ultrasound to evaluate reversible causes of shock rapidly in patients with undifferentiated hypotension, dyspnea, or cardiac arrest. When you approach the patient in shock, you need a special set of tools, and each of us has slightly different tools, but ultimately we all aim to reach the same goal, which is making the correct diagnosis of the patient's shock state and doing so rapidly. My tool to accomplish this is ultrasound, and more specifically, the rapid ultrasound in shock protocol. Similar to the FAST exam, RUSH combines multiple ultrasound exams to assess patients with undifferentiated shock. But unlike most ultrasound exams, RUSH looks at physiology as opposed to anatomy. The value of this is that you gain an understanding of how to resuscitate your patient. Are fluids the next best step, or could fluids harm your patient? Do you need to get set up for a life-saving procedure? Many of these questions can be answered rapidly, and we will review the specific ultrasound exams that are performed as part of this protocol. We will also discuss the 4 types of shock: cardiogenic, obstructive, hypovolemic, and distributive, and discuss the ultrasound findings you might see in each of these states. Then we will learn how to use ultrasound to guide a resuscitation of the shock patient and monitor hemodynamic status following interventions. And finally, we will discuss real-life cases from my own practice where performing the RUSH exam made a difference in the management of my patient's shock. The indications to perform a RUSH exam include undifferentiated shock or dyspnea, assessment of volume status, and cardiac arrest. Ultrasound is also useful for guidance of critical procedures in the shock patient, including central lines, pericardiocentesis, and thoracentesis. However, we won't cover these in today's webinar. Using a plumbing analogy is helpful not only to remind ourselves of the pathophysiology of shock, but also to remember the ultrasound exams that make up this protocol. The first step in evaluation of the patient in shock is a goal-directed echocardiogram to evaluate the pump. The second part focuses on the effective intravascular volume status, which is referred to as the tank. And the third step examines the pipes, or the arteries and veins. When assessing the pump, we ask ourselves 3 specific questions. Is there pericardial effusion? How good is the ejection? And is there right ventricular enlargement? These 3 questions can be remembered easily as the 3 E's: effusion, ejection, and enlargement. Here we are comparing 2 parasternal long-axis views of the heart, assessing for the presence of pericardial effusion. The ultrasound transducer is on the anterior chest wall just lateral to the sternum at approximately the 3rd or 4th intercostal space. The orientation marker will be pointed towards the right shoulder or the left elbow, depending on the convention where you practice. Here we see a pericardial effusion in the example on the right. We see black or anechoic fluid in the posterior pericardial space. In the parasternal long-axis view, pericardial fluid is seen anterior to the posterior pericardial reflection and the descending aorta. Larger pericardial effusions may wrap circumferentially around the heart and be seen anteriorly as well. Here we are comparing an example of pleural effusion to pericardial effusion because we don't want to mistake these 2 entities. Pericardial fluid remains anterior to the descending aorta, whereas pleural fluid will track posterior to the descending aorta, as seen in the example on the left. Here we are performing a subxiphoid cardiac view, with the transducer placed inferior to the xiphoid process and the orientation marker pointed towards the patient's right side. The transducer is aimed up towards the chest, scanning through the liver for a 4-chamber cardiac view. The example on the right shows a large pericardial effusion. Once an effusion is identified, the next step is to evaluate the heart for signs of tamponade. Here we see collapse of the right atrium and right ventricle during diastole. In the patient in shock, this is a sign of cardiac tamponade. Next, we perform a qualitative assessment of left ventricular function to indicate the strength of the pump. Here we focus on evaluating motion of the left ventricular walls by a visual estimation of the volume change between diastole and systole. A ventricle that has good contractility will have a large volume change between the two cycles. Another marker for systolic function is the movement of the anterior leaflet of the mitral valve. In a normal heart, the mitral valve should be seen slapping the interventricular septum. In contrast, a poorly contracting heart will have a small percentage change in the movement of the walls between the two cycles, and the mitral valve does not reach the interventricular septum. Another category of cardiac contractility, known as hyperdynamic, demonstrates small, empty chambers and vigorous, hyperkinetic contractions that may obliterate the ventricle in systole. This is often seen in distributive shock or hypovolemic states. Finally, we look for right ventricular enlargement or right heart strain, a potential sign of a large pulmonary embolism in the patient in shock. An ideal view to evaluate the size of the right ventricle is the subxiphoid view, which allows us to compare the size of the right ventricle to the left ventricle. The right ventricle is normally less than 60% of the size of the left ventricle. When the right ventricular size equals or is larger than the left ventricle, right ventricular strain should be suspected. Another view to assess the size of the right ventricle is the peristernal short axis view. Here we rotate the transducer from the peristernal long axis 90 degrees so that the probe marker is towards the patient's right hip, cutting a plane through the heart in short axis, allowing us to assess the size of the right ventricle. A sign of right ventricular strain is flattening or bowing of the interventricular septal wall. Increased right-sided pressure causes a D-shaped left ventricle. The second part of the RUSH protocol focuses on the tank to determine the effective intravascular volume status. First, we assess how full the tank is, whether there is a leak of critical fluids out of the vascular circuit, and if the tank is being prevented from filling. To assess fullness of the tank, we examine the IVC. The size of the IVC and its changes during respiration can tell us something about a patient's volume status. To assess the IVC, we place a transducer in a subxiphoid position with the orientation marker pointed towards the patient's head. This will give us a long axis view of the IVC. We assess the overall size of the IVC, and here we are looking for extremes. An IVC diameter that is less than 2 centimeters is considered small, and I will refer to this as a flat IVC. An IVC diameter that is larger than 2 centimeters is considered large, and I will refer to this as being a fat IVC. Next, we look at collapse. As a patient breathes, the intrathoracic pressure decreases, pulling blood from the lower half of the body towards the chest, causing a normal pattern of inspiratory collapse that can be as much as 50%. But when the IVC is small and collapses more than 50%, this suggests a low volume state. When the IVC is large and collapses less than 50%, this suggests a high volume state. To answer the second question, whether the tank is leaky, our FAST exam will help us identify fluid in places that it doesn't belong. including fluid in the chest, fluid in the abdomen, and pulmonary edema. And our last question, whether the tank is being prevented from filling, can be answered by performing a lung exam to evaluate pneumothorax. So let's take a look at the IVC. In the long axis subxiphoid position, we identify the convergence of the IVC with the right atrium to confirm that we are in fact looking at the IVC and not the aorta. The IVC should pass through the liver, and the hepatic veins should be seen draining into the IVC. The diameter of the IVC should be evaluated at a point distal to the convergence with the hepatic veins. You'll notice the normal pattern of inspiratory collapse as the patient breathes. When the IVC diameter is small, less than 2 centimeters, and collapses more than 50% with inspiration, this suggests a low volume state such as hypovolemic or distributive shock. The IVC can also be examined in a short axis view, which allows a more accurate assessment of the degree of IVC collapse. Here we have rotated the transducer from the long axis position 90 degrees with the transducer orientation marker towards the patient's right side. Here we are performing M mode or motion mode to give us a graphic representation of the changes of the IVC as the patient breathes. The ultrasound machine translates motion along the M mode cursor and draws the changes over time. The wavy black line in the center of the M mode tracing is our IVC. Its maximum diameter is just under 2 centimeters. But when the patient breathes, the IVC nearly completely collapses. It is important to know that you don't have to measure the IVC. Visually observing the changes of the IVC during respiration is just as useful. Now let's look at a fat IVC. This is a large IVC that measures over 2 centimeters and has minimal collapse during inspiration, suggesting a high volume state such as cardiogenic or obstructive shock. We rotate the probe 90 degrees and take a look in the short axis. Here is an M mode tracing of a plethoric or flat IVC that changes minimally during inspiration. Sniffing is a way to accentuate the changes of the IVC. So if you're not seeing changes during normal respiration, you may ask the patient to sniff, which may accentuate the dynamics of the IVC. The next step is to look for leakiness of the tank, or a loss of critical fluids from the core vascular circuit. Here we are performing a FAST exam. This is a right upper quadrant view of Morrison's pouch. The transducer is placed in the anterior axillary line at approximately the 7th to 9th rib space, with the orientation marker pointed towards the patient's head. Black or anechoic fluid is seen in Morrison's pouch, between the right kidney and the liver. Here is a suprapubic view, with the transducer on the lower abdomen, just superior to the pubic symphysis, and the orientation marker towards the patient's right side, scanning up and down to look for fluid posterior to the bladder. We can also look for fluid in the thorax, which will appear as black or anechoic fluid superior to the liver or spleen, and will allow transmission of the ultrasound beams through the chest to the thoracic spine. Next, we place the transducer on the anterior chest wall with the orientation marker towards the patient's head, looking for evidence of volume overload, such as B lines, which signify pulmonary edema. It is useful to know that the ability to visualize B lines rules out the presence of pneumothorax in that space. Then we assess for tank compromise, or tension pneumothorax, where venous return to the heart is limited by increased thoracic pressure. This slide is meant to remind you of the placement of the ultrasound transducer to evaluate pneumothorax. In a supine patient, we expect free air to be located in the most anterior portion of the chest. Depending on the size of the pneumothorax, you may need to scan several interspaces to rule out pneumothorax. Normal lung sliding occurs when opposed pleural surfaces appear to slide against one another during respiration, resulting in a shimmering effect, as in the example on the left. In the presence of pneumothorax, the pleura are no longer opposed, and this sliding will disappear. The third and final step in the Rush exam is to evaluate the pipes of the circulatory system. Starting with the arterial side, we examine the abdominal aorta, the aortic root, and the descending thoracic aorta, looking for aneurysm or dissection. If a thromboembolic event is suspected as the cause of shock, we can examine the venous side of the pipes, including the femoral and popliteal veins. To scan the abdominal aorta, we place the transducer in the subxiphoid position with the orientation marker towards the patient's right side. Using the spine as our landmark, we look for the abdominal aorta and follow it inferiorly until the bifurcation, which usually occurs somewhere around the umbilicus. You want to pay special attention to the aorta below the renal arteries, since this is where most AAAs are located. An abdominal aortic aneurysm is defined as anything over 3 centimeters. If you see an abdominal aortic aneurysm with thrombus, you should make sure to include the thrombus in your measurement. In patients with suspected thoracic aortic dissection, we can perform an echo to look for aortic root dilation and examine the descending thoracic aorta for dilation or intimal flap. The aortic root and thoracic aorta should measure less than 4 centimeters, and an intimal flap will appear as an echogenic line within the lumen of the aorta. Now let's take a look at the veins. Here we are performing a DVT exam at the level of the femoral vein, with the transducer placed just inferior to the inguinal crease and the orientation marker pointed towards the patient's right side. We know that the majority of pulmonary emboli originate from lower extremity DVTs, and clinically significant clots, especially those that cause PE and shock, are usually large and extend between multiple sites in the lower extremity. Research has shown that a limited 2-point compression exam at the common femoral vein and popliteal veins is an accurate and acceptable alternative to whole leg DVT ultrasound. In fact, many emergency radiology departments perform a 2-point exam as opposed to the whole leg exam. Normal veins will completely collapse with a small amount of pressure from your transducer, whereas a vein with thrombus will not collapse. So how do you know if you've applied enough pressure? Once you see the artery beginning to be compressed, you know that you have applied enough pressure that the vein should be collapsing as well. It's important to understand that whether or not you see an echogenic thrombus, as in the example on the right, a non-compressible vein suggests thrombosis. Here we have the ultrasound transducer in the popliteal fossa with the orientation marker towards the patient's right side to assess for the presence of popliteal DVT. Applying compression, we see the popliteal vein does not completely collapse, suggesting the presence of thrombus. Now that we've reviewed the components of the Rush exam, let's talk about shock. We have 4 types: cardiogenic, obstructive, hypovolemic, and distributive. Cardiogenic shock is a result of cardiac dysfunction, and as we've seen, can be imaged on ultrasound as systolic pump failure. Obstructive shock includes tension pneumothorax, cardiac tamponade, and massive pulmonary embolism. Hypovolemic shock includes blood loss and dehydration, and distributive shock includes sepsis, anaphylaxis, and neurogenic shock. No matter how you approach undifferentiated hypotension, it is critical to identify your patient's specific shock state so that tailored treatment can be delivered rapidly. Most of us know that the knee-jerk reaction to resuscitating a hypotensive patient is to give fluid, but we have to remember that the goal of volume expansion is to increase stroke volume and subsequently increase cardiac output. How can you predict if this will happen in your patient? Well, you could always give a fluid challenge and see how the patient responds. But there's evidence showing that over-resuscitation can be just as dangerous as under-resuscitation, so it is important to be accurate and do no harm. So let's review. The rush exam is composed of 3 parts: the pump, the tank, and the pipes. But there's no reason you have to perform it in that order. In fact, I'm going to show you why I always start with the IVC, or the tank. Using your evaluation of the IVC, you can quickly eliminate 2 shock states from your differential. If the IVC is normal or small, cardiogenic and obstructive shock are unlikely. So your next step is to look for fluid where it doesn't belong, and in the right patient, you may also look for aortic emergencies. Looking at the pump, you may see a hyperdynamic heart, confirming what the IVC told you. And as you resuscitate with fluids or blood, you can repeat the IVC exam to make sure we're seeing it fill appropriately. Now, if the IVC is distended and not collapsing, hypovolemic and distributive shock are unlikely. So your next step is to look at the pump for tamponade, acute right heart strain, depressed contractility, and evaluate the tank for pneumothorax. If the picture fits, you can next look for DVT. Because shock is such a complicated and dynamic process, it is recommended to perform serial exams during your resuscitation. Each exam gives you more information after giving fluids, starting pressors, or if the patient suddenly decompensates. Here we are repeating our IVC exam after giving IV fluids, and what we see is that the IVC is now more full. However, there continues to be respiratory variation, suggesting that we still have room to give more fluid. This is important because the ideal situation is to completely volume resuscitate your patient prior to initiating pressors. Let's discuss the special case of shock in the intubated patient. Here the hemodynamics are a bit more complicated, but you can still learn valuable information about the specific shock state. Positive pressure ventilation causes the inferior vena cava and right atrium to become more compliant, and in most patients the IVC becomes enlarged. Because venous return occurs during the expiratory phase, this is when you would expect to see a change in the size of the IVC, although here the percentage change only needs to be about 20%. Therefore, if I am able to appreciate a change in the IVC size in an intubated patient, I proceed with a fluid challenge. If you see a plethoric IVC that is large and shows no change, volume expansion is unlikely to benefit your patient. And remember to always perform serial examinations to assess responsiveness. So while I prioritize assessment of the tank, you should be aware of the limitation of IVC ultrasound. Any structural abnormalities that exert pressure or obstruct the IVC, such as masses or advanced cirrhosis, may interfere with its normal dynamics. Similarly, severe valvular problems or pulmonary hypertension will inherently interfere with the size and respiratory variation of the IVC. And don't forget that patients can present with overlapping shock states, which is even more of a reason to repeat your exam looking for trends. So let's put this all together and review the ultrasound findings you may see by shock state. In patients with hypovolemic shock, we expect our pump exam to show a hyperdynamic heart. Because the tank is empty, we expect to see a flat IVC, meaning that it is small with lots of collapse during inspiration. Next, we look for the cause of the hypovolemic shock. That might be free intraperitoneal fluid, pleural fluid, or possibly AAA or aortic dissection. In distributive shock, we usually see a hyperdynamic pump. In the late stages of sepsis, we may start to see poor contractility. Again, our tank is empty, so we expect to see a flat IVC. Our tank assessment may also show us free intraperitoneal or pleural fluid, but the pipes should be normal. In obstructive shock, our tank is full, so we see a fat IVC. And here our pump exam seeks to look for cardiac tamponade or right ventricular strain. Scanning the lungs, we look for absent lung sliding, which is a sign of pneumothorax, and we can examine the lower extremities for DVT. In cardiogenic shock, we expect to see poor contractility. The tank is full, so we see a fat or plethoric IVC with minimal change. Doing our lung exam, we may see B lines, also called lung rockets, which are a sign of pulmonary edema. We may see pleural effusion, but our pipe exam should be normal. To help us apply what we've covered today, let's review some of my personal cases in which ultrasound helped me determine shock state when it wasn't immediately obvious. The first case is a hypotensive patient with relative bradycardia. Your patient has known liver disease, which makes these vital signs difficult to interpret, and laboratory data is not immediately available. So let's perform our rush exam. Here is an M-mode tracing of the inferior vena cava. As the patient breathes, we see the walls of the IVC come together. Our tank assessment reveals a low volume state, so now we are considering hypovolemic and distributive shock. We perform a fast exam and see free peritoneal fluid. Our pump assessment shows us good contractility. And for good measure, we check the aorta, which is normal. Based on the collapsibility of the IVC, we know that this patient may benefit from fluids. This provides a context now to initiate resuscitation and with which to interpret the patient's vital signs and laboratory data as they become available. Case number 2 is a 65-year-old male with shortness of breath and cough who was recently discharged from another hospital after myocardial infarction, which was complicated by gastrointestinal bleed. The differential diagnosis for this patient includes all 4 types of shock. So we perform our rush exam. Our tank assessment shows a large IVC with minimal respiratory variation. This suggests cardiogenic or obstructive shock. Our pump assessment shows poor contractility, suggesting systolic failure. Lung ultrasound shows further evidence of volume overload. We see lung rockets or B lines, which signify pulmonary edema. And our fast exam shows us a large pleural effusion. So now we know that the treatment of this patient needs to consider the possibility of acute CHF exacerbation. And we should be careful about starting fluids in a patient who already has evidence of volume overload. This patient's final diagnosis was acute congestive heart failure, exacerbated by hospital-acquired pneumonia. This is one of those tricky cases where the patient had a mixed shock state of cardiogenic shock as well as distributive shock. Understanding his overall volume status is important since the standard treatment of sepsis by administering large amounts of fluids would likely have harmed this patient. Our third case is a young female with abdominal pain, hypotension, and tachycardia. The tank assessment reveals a flat, collapsing IVC, suggesting hypovolemic or distributive shock. Our pump exam shows a hyperdynamic heart, confirming a low volume state, and now we can start treating with fluid. The fast exam reveals free intraperitoneal fluid in Morrison's, in the left upper quadrant, and in the pelvis. Without a history of trauma, the diagnosis until proven otherwise is ruptured ectopic pregnancy, and the immediate treatment is volume resuscitation with fluid or blood and emergent exploratory laparotomy. Our next case is a young man with shortness of breath and chest pain. Let's take a look at the tank. Watch for a few heartbeats. This mid-size IVC is not collapsing with inspiration, but rather dilates with every beat of the heart. This tells us that there's a downstream obstruction causing reverse flow, and if you don't look close enough, this could be mistaken for a collapsing IVC. A quick check of the pump in parasternal long axis view shows normal systolic function. We rotate into the short axis view and see a D sign, indicating elevated right ventricular pressure. If you stopped here, you have enough data to start treatment for pulmonary embolism. But a quick scan of the lower extremity shows a large clot in the femoral vein. This patient had massive PE with right ventricular strain. Our last case is a 68-year-old male with chest and abdominal pain and a history of hypertension. Our scan of the IVC shows a flat, empty tank. The pump evaluation shows normal contractility, but something looks wrong. Pay attention to the descending thoracic aorta. It is massive. This is a view in the suprasternal notch. This is an advanced view, but what we're seeing here is an enlarged aortic arch and an echogenic intimal flap. As we move down into the abdomen, we see aneurysmal dilation of the abdominal aorta. This was a type B thoracic aortic dissection. Some pearls to remember as you apply this to your practice. Shock is a dynamic process, and one exam may not provide sufficient data. Repeating components of the rush exam, such as the IVC and lung, especially after an intervention such as giving fluid, or if a patient suddenly decompensates, will improve your diagnostic accuracy. Remember that patients may have a mixed picture, such as the CHF exacerbation who was also septic due to pneumonia. There are exceptions and special cases that you have to be aware of in order to use the rush exam to benefit your patients. Remember that if a patient is on a ventilator, positive pressure reverses the changes of the IVC, and in most patients will cause the IVC to become larger and less compliant, so that if significant change is seen during the respiratory cycle, the patient may benefit from volume. The rush exam is a collection of core exams that many critical care and emergency physicians are already performing. Research has shown that applying a resuscitation protocol improves accurate diagnosis in undifferentiated shock. One study compared treatment plans, presumed cause of vital sign abnormality, and the degree of certainty in the cause of shock, both before and after ultrasound findings. Treatment plans were changed in more than half of the cases. This suggests that accurately diagnosing a patient's shock state using ultrasound may translate into better outcomes for our patients. While the rush exam emphasizes multiple ultrasound applications, it may not be necessary to perform all of the components of the exam in every critically ill patient. For example, in a younger patient, it may not be necessary to evaluate for AAA, and DVT exam may be omitted if PE is not on your differential. Finally, remember to perform serial evaluations of the IVC to determine adequacy of resuscitation and improve your diagnostic accuracy. Thank you for attending this webinar. I hope you found that this information will help improve the care you provide to your patients.